Welcome, and I am very pleased to join you this evening for another webinar brought to you from Heal with Laser. And we're just waiting for our participants to come in and say welcome to people. Hi, Kate, how are you? You're saying hello, and what a good evening it is. So while people are coming in, I will just check that we can see the chat. There's the chat. Good morning from the UK. There's Steve. How are you, Steve? Welcome aboard. Nice to have you here. And that's people are coming in right now, so that's a great thing. Hello all, Sharon Tilley. Great to have you on board, Sharon. In fact, I'm just thinking and remembering of when we first met back in 2016 in Darwin, and that was my first introduction to the world of lymphedema. And I know people like yourself have been practitioners for a very long time. So I know I've certainly learned a lot from everyone. Now let's just, I'll just do my introductory slides while we're waiting for people to come on in. And as you can see, this is the second webinar that we're doing with Dr. Jolien Robijns, and it's on lymphedema. For those of you who joined us for the radiation dermatitis webinar on the 12th of August, I think you remember, I think you know that it was one of the very impressive webinars, and we got a lot of extremely good feedback from people. So we're excited to have Jolien with us here again tonight. And tonight her topic is on lymphedema. So a very, very interesting topic. Just a reminder, Heal with Laser, we partner with practitioners to provide innovative laser technology to enhance clinical outcomes. And our mission is to help you get patients better, faster, and in a safe way. So that's important. Laser offers a pain-free, drug-free, non-invasive therapeutic solution. Now, some of the things about MLS high-powered laser we've been talking about in the last couple of webinars: accelerates rehabilitation, and particularly in lymphedema, it improves activity and increases comfort for patients. So some of these things are very important. As I said before, one of the questions I get asked a lot is, well, where's the evidence? What's the research behind using laser for supportive cancer care? So what we're going to do tonight is talk about some of that evidence, show you that the laser actually works and explain how it works, and review some results that can be achieved. So that's our purpose tonight. Our presentation's going to run for about 40 minutes. And you know the drum, at the end we'll have time for questions. So there's a chat box, you can use that. And then at the end, I've got a link to a couple of resources and also some offers for attendees. So I say to Jolien, welcome in my best foreign language. And this is our presenter tonight, who's highly involved in research, looking at acute radiodermatitis and getting more involved now with lymphedema. And I encourage you to take a look at the Low Light Institute, a collaboration between University Oncology Centre and hospitals in Belgium. And they're doing some very exciting things. You can find great research there. So please take a look at that. Some of the research topics that we looked at last time were in lasers and medical science, the Belgian Journal of Medical Oncology. These are areas where Jolien has published, and some of the very, very fine research that she's doing. And she's just returned from a conference in Spain where she's been presenting her work. So we truly are very fortunate to have such an international presenter. Now, the laser that is going to be reported in this research is the M6 scanning laser, and it is a super pulsed and continuous laser emissions. So we'll be talking more about this through the research, but I actually have got a short video, just 20 seconds, to show you the laser, because after the last presentation, many of you asked about the M6 laser. What does it look like? How does it work? So just a very, very short video, just 20 seconds, so you get a sense of what it's like. And you can see that it's a fully robotized unit. It's a scanning laser. Basically, you press the buttons and the laser then moves. You set the parameters and the laser will reach the various areas of the patient. And it's got, you can move the laser around to suit the patient and reach the patient. So that's what it looks like. Very versatile, designed with the patient and the clinician in mind. Okay, so now I'm going to invite Jolien to come on board and ask you to unmute and to join us with your video, Jolien. And I'm going to turn it over to you now, and welcome.
Hi, good day.
Hey, how are you feeling tonight?
Good, thank you.
Very good to have you with us. This is a very popular topic, and we've got many people from many countries around the world joining us tonight. So it's your morning, isn't it?
Yeah, it's around noon or now here.
Around noon. Okay, then.
Yes.
All right. Well, thank you very much. And we look forward to hearing from you. And we'll have the questions at the end. Is that okay?
Yeah, that's great.
Okay. Thanks so much. Bye.
Okay. Thank you. All right, so good evening, everyone. Again, very pleased to be here today for this webinar for Heal with Laser, and I thank Catherine and Annabelle for the organization of this second webinar on lymphedema. And first of all, I have to say that I'm new in the lymphedema field. I did a lot of research in oral mucositis and acute radiodermatitis, but since the beginning of 2021, we also started studying the PBM and especially the M6 laser effects on lymphedema, and especially breast cancer related lymphedema. So it will be more specifically on this topic today. So, and to start off my presentation, I want to show you this cartoon to bring it under the attention. And lymphedema is often a side effect of cancer therapy that is unrecognized. So the oncologists and the radiotherapists, they do not really speak about this side effect during the consultation with the patient. They only speak about it when the problem is already there. So we also, with our research group, want to improve that and think about more how can we prevent the development of lymphedema and bring it more under the attention, also with radiotherapists and oncologists. So the topic of today is photobiomodulation therapy for the management of cancer-related lymphedema. And as Catherine already told you, I'm a postdoctoral researcher at the Limburg Clinical Research Center, which is a collaboration between Hasselt University and the two main hospitals in the province of Limburg in Belgium that are Jesse Hospital and Ziekenhuis Oost-Limburg. And we also started up our own research institute, which was called Lowlight. And this is a research center in which we are doing research in the field of PBM and specifically into supportive cancer care. So today I will give you first a short overview, what is lymphedema and how does it develop, and then I will go further into the research on PBM and lymphedema. So the lymphatic system, as you probably all know very well, it is divided into several parts. You have, of course, the lymph fluid, which consists of the fluid that is absorbed in the interstitial tissue that contains lymphocytes, proteins, fats, also waste substances, and it is transported from the interstitial tissue via the lymphatic vessels towards the lymph nodes. So here you can see on the left also a picture of the lymphatic system of the human body. And when the lymph fluid is eventually via the lymphatic system transported towards the lymph nodes, and in the lymph nodes, the lymph fluid is filtered, and there are also the lymphocytes that are attacking the foreign substances and like viruses or bacteria, and so they are destroyed in the lymph nodes, and eventually all the excess fluid is then transported to one of the two lymphatic ducts, the left or the right collecting ducts, which you can see here over right, and then it flows back into the blood system. So the main functions of the lymphatic system are, of course, the draining of lymph fluid, and also the draining of the excess fluid that accumulates in the interstitial tissue. Lymphatic system is part of the immune system, so it can attack foreign invaders like viruses, bacteria, but it also removes waste from the human body. So that are the three main functions of the lymphatic system. Now, in a normal functional lymphatic structure, so the lymph fluid is absorbed by lymphatic vessels in the interstitial tissue, and then it is transported via the lymphatic vessels towards the lymph nodes, and that is transported via the movement of the lymphatic vessels. So the smooth muscle cells, they contract and they push the lymph fluid towards the lymph nodes, and the retrograde flow of the lymph fluid is inhibited by the presence of lymphatic valves, which you can see here on this picture. So the lymphatic valves prevent that the lymph fluid flows back into the interstitial tissue, so the lymph fluid flows towards the heart region. So that is what is occurring in a normal human being with a normal working lymphatic structure. Now, this is what happens in a patient with, for example, cancer-related lymphedema. So in these patients, they are characterized by an accumulation of interstitial fluid in, on the left, the upper limb, so in the arm, and on the right, on the lower limb, so on the leg. So that is caused by damage towards the lymphatic structures. And in this case, there is an overload of overload of fluid in the interstitial tissue due to a disruption in the lymphatic flow. And this disruption in lymphatic flow can be caused by, for example, surgery, cancer-related surgery, for example, lymph node removal, for example, in breast cancer patients, or in gynecological cancer patients or prostate cancer patients, for example. But it can also be aggravated in case of radiotherapy. So when patients undergo radiotherapy, radiotherapy can also cause damage to the lymphatic structures, which also enhances the development of lymphedema and also enhances the development of fibrosis of the lymphatic structures. And in these patients, there is a quite severe form of lymphedema present. And of course, it is accompanied with a lot of pain, heaviness, difficulties in daily activities. And of course, it affects their quality of life severely. So therefore, for these patients, we surely need to find a solution to tackle this side effect. The incidence of lymphedema in various cancer patients is really dependent on a variety of factors. It also depends on the type of cancer, the type of surgery they underwent. Did they underwent a combination with chemotherapy, radiotherapy, or not? That all influences the incidence of the lymphedema. So here you can see some numbers, and you can see that in breast cancer patients, the incidence lays around 6% when patients undergo only a sentinel lymph node biopsy, while patients who also underwent an axillary lymph node clearance have a much higher incidence, with around 20% of the patients who develop lymphedema. But not only in breast cancer patients, we also see it in other cancer patients like Gynecological cancer patients with also a higher incidence, around 40%, but also a melanoma, skin cancer, head and neck cancer patients, and patients with a prostate cancer, for example, it lays around 10%. So it is still a side effect that is seen quite often nowadays in clinical practice, but it is often a problem that develops after the cancer treatment. Some of the patients are not regularly in the hospital anymore, and that's why it's not always recognized as early enough. So that's why we have to bring it under attention by the oncologists and radiotherapists. So how does lymphedema exactly develop? So I explained to you in an earlier slide that in a normal situation, lymphedema, the lymph fluid flows towards the lymph nodes via the contraction of the smooth muscle cells around the lymph vessels. But in case of for example, lymph node removal, there will be the lymph flow will be reduced towards the lymph nodes, and in this case the lymph structure will also change. So in first instance, the basement membrane will become thicker, and also there will be a hyperproliferation of smooth muscle cells. And it will also be combined with inflammation of the lymphatic structures, and inflammation will also lead to regression of the lymphatic valves. So eventually the lymphatic valves will become incompetent, and that will also enhance the retrograde lymph flow. So the lymph will not flow anymore towards the heart, but it will flow back into the interstitial tissue, and that will eventually lead to the accumulation of the lymph into the interstitial tissue of the limb, the lower or the upper limb. And in case of a chronic case of lymphedema, you don't only have the dysfunctional valves, but you also have more fibrosis of the lymphatic structures, and also fat accumulation can occur. So that is what happens in case of you don't manage lymphedema from the beginning. Now, I already explained to you in an earlier slide that there are different factors that can enhance the development of lymphedema. And on one side, you have the treatment-related risk factors. The treatment-related risk factors are, for example, like I explained to you, lymph node removal. So also the higher the number of lymph nodes that are removed, the greater risk there is on lymphedema. Also the combination with surgery and chemotherapy, and especially radiotherapy, because radiotherapy also enhances the fibrosis, also gives the patient a higher risk on developing lymphedema post-radiotherapy. Also trauma to the affected limb can also increase the risk. And also, of course, metastatic disease. So the number of lymph nodes that are affected by the cancer. On the other hand, you can also, of course, also have the patient-related risk factors. And there are, for example, a poor nutritional status, patients with already expressing skin disorders, patients with obesity and hypertension, diabetes, chronic kidney disease, cardiac disease, patients with reduced mobility, they all have an increased risk on developing lymphedema. So we have to pay attention also to reduce those specific patient-related risk factors that can be modified by the patient itself. Then for lymphedema, we have different stages, and they have been defined by the International Society of Lymphology, so the ISL. And a stage 0 is characterized by it's a subclinical state, so it is a latent condition where the swelling is not yet evident, but there is already impaired lymph transport, and there can be subtle alterations in tissue and fluid composition. And some patients already experience some subjective symptoms like changes in heaviness, problems with mobility. So that can already occur before we can really see some changes to the lymph. In case of a stage 1 lymphedema, there is already an early accumulation of fluid, which is relatively high in protein content and which can subside with lymph elevation. And in this situation, pitting may already occur. In a stage 2A lymphedema, lymph elevation rarely reduces the tissue swelling, and pitting is in this case manifest. Stage 2B, the lymph may pit or not as excess subcutaneous fats, and also fibrosis already can develop in this type of stage of lymphedema. And finally, you have the stage 3, the most severe form of lymphedema, which is also called lymphostatic elephantiasis. And on the exam, pitting is absent. Tissue is very hard due to the fibrosis, and the skin will also have sometimes tropic skin changes, so as fat deposits, and also warty overgrowth. Now, how do we diagnose lymphedema? There are different methods to do so. So you can do it by just doing a clinical exam of the patient's lymph. Then you can look at pitting, peu d'orange. But the difference is that you cannot really distinguish the different stages by just looking at the arm during a physical examination. So therefore, we also often include a diagnostic parameter to also measure the change in lymph volume. And the most used method, and the method also we are using in our research, is measuring the lymph volume change by a circumference-based tape measurement. So we are measuring the arm, so the affected arm and the control arm, on different segments, and then we are comparing the difference between the control arm and the lymphedema arm. It's an accurate method, and it's also very easy to do. But of course, it takes some time to do so. So it takes a little bit more time than just looking at the arm during a physical examination. What you also can do, but when you need to have some extra equipment, you can also measure the arm volume via the water displacement method or via a pyrometer, so a pyrometry, where you put the arm or the lymph in a device that can measure also the volume of the affected lymph. But we are doing the circumference-based method. There are also more technological measurements. So you can do a bioimpedance spectroscopy, but you need to have the device, and it's also not really expensive to buy. Then you can also do a measure via a tissue dielectric constant. But also you need to have the special equipment for it. And you can also, of course, it's more specific method. It's the high specific method is using an imaging technique to see the dermal backflow pattern of the lymphatic structures. And this always, of course, have to be done in a clinical situation when you have the device and the specific equipment for it. So at the moment, there is still no consensus on which is the best method to use. And from my experience, most of them are using the circumference-based methods and in combination with a physical exam. How can we prevent lymphedema? So in patients who underwent, for example, breast cancer surgery or surgery when there is lymph node removal, with or without radiotherapy, we always need to monitor their lymphedema by taking measurements on specified moments to see if there is any change in arm volume or lymph volume. Patients also need to take care of their skin hygiene and nail care. Exercise is recommended, but patients may not exaggerate with that. We also prohibit the patients or the nurses to avoid any medical procedures in the affected arm, so to puncture the skin, because that can also enhance infection. Also the ideal body weight, so patients who are obese are also recommended to lose some weight, because that will also reduce the risk on lymphedema. Also, the blood pressure measurements needs to be done in the unaffected arm, and patients are also recommended to prevent extreme heat and extreme cold, because that can also enhance the development of fluid accumulation in the limbs. And of course, a little bit the same as I told earlier, it is important to avoid trauma, infection in the affected arms or lower limbs. Now, eventually, when lymphedema has developed in the patient, what can we do? And of course, you all know that there are some standard therapies to use. And of course, one of those main therapies is manual lymphatic drainage, which is of course a very good therapy to reduce the accumulation of lymphatic fluid. Next to that, the patients can also do decongestive exercises in combination with a good skin care. And in case of a more severe type of lymphedema, also compression therapy can be applied by bandaging or by applying a compression garment. But up to date, there is still no consensus on which is the most effective therapy, and most of the time it is a combination of all four compartments which is recommended for patients with lymphedema. But therefore, we are still looking, and our research group wanted to see, can we use PBM to treat patients with lymphedema, and especially cancer-related lymphedema. So we first went into research, and we first did a literature study to see what is already studied in this field. And we first found one study. It was an in vivo study with mice. It was a study that was published in 2016 by a Chinese research group. And they studied the anti-inflammatory and the lymphangiogenic effects of PBM on lymphedema in an experimental mouse tail model. So what did they do? They set up a study with 3 different groups of mice, one control group, one PBM group, and one placebo group. There were all 10 mice in each group. The control group only underwent a surgical incision of the tail without the lymphatic cautery. And then the laser group and the placebo group, they all underwent the surgical incision in combination with the lymphatic cautery. The difference between the PBM group and the placebo group is, of course, that the PBM group received PBM and the placebo group received the placebo PBM treatment. On the right, you can see the PBM parameters that they applied. So they used a device of 904 nanometers with a fluence at 1.5 joule per square centimeter, and the total treatment time per session was around 10 minutes, and they applied it for 12 daily sessions post-incision. And then they looked at different outcome measures in these 3 groups of mice. So first of all, they looked at the macroscopic changes. So in general, they just looked at the thickness of the tail. And on the left, you can see the pictures of the tail that they took up to 12 days post-incision. And on the right, you can see the measurements in millimeter that they collected also in this same time frame. And what you see that there is a significant difference at day 10 and day 12 post-incision between the sham and the PBM treated group. So the tail was significantly thicker in the sham treated group in comparison with the PBM treated group, which indicates that PBM did have an effect on the tail thickness in this group of mice. Then they also looked at histology. And on the left here, the first panel shows you the control animals, the middle panel, the sham treated animals, and the right panel, the laser treated panels. And in general, you can see that the amount of inflammation is much lower in comparison with in the PBM treated group, in comparison with the sham treated group. Also, the fluid accumulation is also much less, which also indicates that here the PBM also has an influence on the inflammatory processes in the tail. And it is also shown when we're looking into the macrophage count. So they also counted the number of macrophages, a number of inflammatory cells in the tails, in a biopsy of the tail. And of course, you expect that there is a low number of inflammation in the control tail. But you see, of course, that it is a little bit upregulated in the PBM treated mice, but there is no significant difference between the control and the PBM treated mice. So in general, there is not much more inflammation compared to the control animals. But when you compare the PBM treated animals towards the control animals, you can see that there is a higher number of macrophages in the sham treated animals, indicating that inflammation is still much higher in these animals. However, there is no significant difference between these two groups. So the p-value is 0.12, but there is a significant difference between the control and the PBM treated animals. So indicating that indeed inflammation is active in these type of animals. So while it is already downgraded in the PBM treated mice. Also, they also looked at the lymphatic vessel regeneration. So we see in comparison with the between the control and the sham treated animals that there is already a regeneration of the lymphatic vessels occurring. So there is already significant difference. So it is a normal healing process of the mice in the mice that is present, that is occurring. But on the other hand, when you compare the control animals, the sham-treated animals with the PBM-treated animals, you can see also a significant difference, indicating that the PBM is stimulating the lymphatic vessel regeneration in these type of mice, that it is really enhancing the process and doubling the lymphatic vessel regeneration. So PBM has both an effect on inflammation, but also on the lymphatic vessel regeneration process. Further, they also looked at the VEGF expression. When they looked at VEGF expression in general, they did not really see any significant difference between all the three groups. But when they looked at the VEGF receptors, so the vascular endothelial growth factor receptors, it also are needed to stimulate the restructuring and the regeneration. You can see that there is a significant increase between the control and between the sham and the PBM treated animals at the end of the PBM sessions. Also indicating that it also influences the down-regulatory processes that are important for the restructuring of the lymphatic structures. So in general, we still do not know exactly how PBM can influence BCRL or lymphedema in general, but based on the studies that we have today, not only the studies that have been done on lymphedema in general, and the studies that we know from the wound healing and from in vitro and vivo studies that we have today, we can say, or we can think about a possible mechanism how PBM can affect lymphedema. So first of all, it can reduce edema that we also saw in other studies with edema, but also in wound healing studies that show a reduction in edema. It possibly also can inhibit the development of fibrosis. It wasn't shown specifically in patients with lymphedema, but it has been shown in specific studies with fibrosis due to other conditions. It also has a proven anti-inflammatory effect, like I showed you in the previous study by Young, but it also was studied in wound healing studies, in rheumatoid arthritis studies. So it has been studied shown in in a lot of studies studying the inflammation process and PBM, and also shown previously it can have an effect on the regeneration of lymphatic vessels. But of course, the data we have today is very limited, but they are showing us the right data. So these are possible mechanisms, but of course we cannot really make a conclusion on this topic today. But we hope, of course, to see more studies in the future. And of course, lymphedema is also accompanied in most cases with pain. And we have seen in previous studies that PBM has a positive effect on pain reduction. So possibly PBM can also have a positive effect on pain reduction in these type of patients with lymphedema. So we hope by applying PBM that we can restore the lymphatic structures, that we can reduce the inflammation of the lymphatic vessels, and thereby also restore the lymphatic valves and improve eventually the lymphatic flow into the human body by applying PBM. Now, that is what we know from in vitro and in vivo studies, or from other studies that have been performed in the field of PBM. But of course, we also wanted to see what happened around PBM and lymphedema in clinical trials. So there were around 3 systematic reviews, one in 2014, one in 2017, and one in 2019, that already have been looking into the effectiveness of PBM and lymphedema. And I will show you the number of studies that already have been performed, and that are around 12. The first study was performed by Karadi in 2003, and the last one was performed this year, or was published this year, by Kozanglu. So around 12 studies, so it's quite good to have them already. And you can see that most of them are randomized controlled trials, so that's a good study setup. And all of them used a laser device, so a laser diode, and the wavelength ranged around 600, 630 up to 905, 980 nanometers. So the wavelength differed a little bit, but most of them were in the near infrared range. And they use effluents between around 1.5 up to 6 joules per square centimeter. So based on the PBM parameters, we cannot really make a conclusion on that. But when you're using a laser diode around between 2 and 6 joules per square centimeter, and we suggest to use, because also to the higher penetration depth, to use a near infrared laser diode, so around 800, 950 nanometers for the patients with lymphedema. So the M6 MLS laser is an ideal device for treating this type of patients. So all studies that have been performed up to 2019 were in patients with breast cancer-related lymphedema. The study by Akul in 2020 was a first study lymphedema. So it was also the only study in patients with lower limb lymphedema. So I think it's important, and in the future also the focus is also placed on these type of patients. I think, in my opinion, the attention is put on the breast cancer patients, because there are of course a lot of breast cancer patients worldwide. So I think, of course, that is a group that will benefit the most from it. But of course, we still need to think about other patients that can develop lymphedema after cancer. Now, most of the studies use PBM as a single treatment, but you can see that some studies, like for example, the study of Rittner, but also the study of Akud and Kozanglu, use a combination of PBM with the standard treatments that we already have today, like manual lymphatic drainage or the compression therapy that we have already available today. Most of them used PBM at least 2 times a week, up to a daily session for at least 4 weeks. So the number of sessions lays around 8 up to 36 sessions in total. When we are looking into the results, and I give you only a short overview, some of them showed positive results, but some of them did not show any difference between the control and the PBM group. Is it due to the difference in parameters that they applied? Is it due to the combination of PBM with the standard therapies? That is something that we still need to look into. Some did not really show any significant difference when they are measuring the arm volume, but the patients really experienced less symptoms. So for example, less pain. They showed an improved mobility after applying PBM. So some that only showed improvement in subjective symptoms and not really in the objective outcome measures. So there are a little bit contrasting results. But when we are looking into the studies that combined PBM with, for example, manual lymphatic drainage or with compression therapy, you can see that there is a better effect when you combine 2 therapies together than when you only apply PBM as a single treatment. So in that opinion, we can state there is only a moderate evidence for the reduction in arm volume and pain by PBM in cancer-related lymphedema patients. But that is also due to the fact that we cannot really compare all the studies, but because they all use different PBM parameters, different type of patients, different settings. But based on the evidence that we have today, we would state that the combination of PBM and the complete decongestive therapy will be more effective than when you only use CDT alone or only PBM alone. So the combination is in our opinion, the most ideal setting. And because, of course, future trials are needed to determine the exact PBM parameters and also the safety of PBM in oncological patients, with also a larger sample size and a longer follow-up period, because in the studies that already have been performed, patients were not followed up to say they collected the final outcome measures at the final PBM session, but they didn't see what were how did the lymphedema develop after the PBM session. So did it come back? Did it stay at the same level? So that is also what we want to know on the long term. So therefore, we set up our own trial. It's called the Lymphoedema trial. The study was started up in January this year at the Jesse Hospital in Hasselt, Belgium. And we want to see if we can use PBM in the management of BCRL, so breast cancer-related patients post-radiotherapy, in combination with the standard therapy, so the manual lymphatic drainage, compression therapy, and exercises if needed, and they were also prescribed by the physiotherapists. So we include breast cancer patients who underwent a lumpectomy or a mastectomy with a sentinel lymph node biopsy or an axillary lymph node dissection, who underwent radiotherapy with or without chemotherapy, and who are diagnosed with a stage 1 or higher lymphedema. And they are all treated at our Jesse Hospital in Hasselt. So we set up a randomized placebo-controlled monocenter trial, which was also registered at clinicaltrials.gov. And we are randomizing our patients according to their stage, so 1, 2, or 3, into the two different groups. So we have the control group and the PBM group, and we expect to enroll around 104 patients. All patients received a manual lymphatic drainage with or without compression therapy, that is applied by the physiotherapists at our hospital. And alongside, the control group receives a placebo treatment, and the PBM group receives a true PBM treatment. They undergo PBM alongside the manual lymphatic drainage 2 times a week for a total of 9 weeks. So they receive 18 sessions in total. So which outcome measures do we collect? So we look at the arm value by the tape circumference measurement. We also look at the shoulder mobility. We ask the patient's pain by a numerical rating scale. We question the patient's activity status, mental health, quality of life, their satisfaction with PBM, and the standard lymphatic therapy. And of course, we also look at the safety of PBM to see if there is any negative effect of PBM. We also did it in our previous studies, and we can say that there is no negative effect, but we still will be doing it for these type of patients. And we are collecting these measures at baseline, at session 9, so halfway, session 18. And we are following up our patients up to 12 months post PBM. So we are evaluating all these measures at 3 months, 6 months, 9 months, and at a 1 year post PBM to see what is a long-term effect of the photobiomodulation. And we are, of course, all doing it with the M6 MLS laser that we already have in our hospital. So I want to thank you for listening to our presentation. I want to thank my team, of course, for helping me with the conduct and the setup of this study at the Jesse Hospital and UHasselt. And if you have any questions, please feel free to ask them now, or you can always send me an email on the email address that you can find here under in this slide. So thank you very much, and I hope to see you soon. Thank you.
Fantastic. Okay, thank you so very much. I'd say obviously we're going to have you back in 12 months' time, right, to find out what's happened.
Indeed.
Indeed, that's really great. We'll certainly look forward to that. Now, we have got a couple of questions here in the chat. There was one question that was asking about comparison with far infrared treatment. Do you have any comments on that?
No, there are not really made comparison between the two. But we opted for the near-infrared light treatment because the tissue penetration depth is better in this case. So when you're using, for example, a red light, so around 630, 650 nanometers, it will be good to treat skin conditions, but it will not go as deep enough into the tissue to also treat the lymphatic structure. So therefore, we also opted to use the M6 MLS laser in this case because the penetration depth is better for this type of condition.
Okay, and can you explain again how you do the sham laser? How does that work?
Yeah, indeed. So all the patients come to our laser unit at the hospital, but we blindfold all patients, so they don't really see if the device is active or not. And in the case of the sham treatment, we install the device over the patient, so it will make the same noise as it is an active laser. But of course, when you activate the M6, it will make a beeping sound. So we have recorded the sound that is coming from an active M6 MLS laser, and we put on that sound during the placebo treatment. So it sounds like it is really active, but due to the face shield that the patient is wearing, they are not aware if it is real or not. So
yeah, very clever. That's very clever. And I assume the doctors don't know?
no, the doctors don't know, the physiotherapists don't know. So only the outcome assessor, so the researcher who is evaluating, that is in this case a study nurse, is evaluating and applying the PBM. They will know who was getting the PBM or the control treatment.
Okay. Now, there was a question from the last webinar that said, have you dealt with PBMT in pain sensitization syndrome?
I also got an email on that topic. So I don't really have experience on this topic, but I sent a person who questioned this an email with some papers who are talking about this topic and who could be maybe more helpful in treating this condition. But I don't really have experience at the clinic in this for this condition.
Okay, that's fine. I think, let me just see, are there any other questions? I think your presentation is very clear and informative, and I love the depth that you went into with the research and explaining, and it sets you up to have a very strong foundation for your own work, doesn't it?
Yeah, indeed.
And has there been anything surprising in your exploration of lymphedema at the moment?
So the inclusions are very slow at the moment. I also think it's still due to COVID that we still have difficulties in recruiting patients. The difficulty that we also saw is a lot of patients who already have lymphoedemas go to a physiotherapist, but they go to a physiotherapist nearby their homes or people who they know. And for the study, they have to come to the hospital. So they need to go make an extra hospital visit, and they need to go to the physiotherapist at our hospital. So sometimes it is a little bit barrier for the patients to make that extra, to make extra time to participate in the study. But up to now, we have 6 patients included. It's still really low, as we expect around 100 patients. But the study will still run up to 3 years, so we still have a little bit time, and I hope that COVID will let it a little bit go faster. But in the patient that we treated already now, we already see a difference between our control and our PBM treated patients. So yeah, we hope to present those results next year at a conference or in a next webinar of Heal with Laser. So
that's already an encouraging beginning.
Yeah, indeed. Yeah.
I think one of the things I found interesting was the effect with the combination therapy. That's got to be encouraging, I think, for a lot of therapists who are listening tonight. Yeah.
I think that it is an ideal combination. I think PBM alone could also help, but I think that the ideal situation would be a combination of PBM with the standard therapy for lymphedema. So in this case, if we eventually show positive results, but there are already positive results shown by previous researchers, I think I would recommend a physiotherapist or everyone who is applying lymphatic drainage to buy a laser device or the M6 to use a combination in these type of patients.
And we have a couple of comments here from Kate, who's already using a laser, saying she's seeing some amazing outcomes in treating fibrotic lymphedema tissue. And there's so that's encouraging, and she's a new user, but she's already seen good results. Now, Sharon Tilley's got a question here, and Sharon ran a course for us last year on treating lymphedema with PBM, and she has a lot of experience. She asked, do you feel that bioimpedance may be more sensitive to detect extracellular volume change than circumferential measures?
Yeah, that could be. We also, in the beginning, before we wrote our protocol, we also thought about including this extra measurement. But due to the limited resources that we have at the hospital, and also due to the extra time that will be needed for the study nurse, we did not include it. And because they're already experienced with the tape measurement method, we just kept it to that. But that could be indeed an extra sensitive method to detect differences. But when we are doing the tape circumference measurements, we also let only one person do the measurements all the study period long for one patient, so that because every person who is doing the tape measurements can have a different method to do, so it's good that only one person is doing it, so there will not be differences caused due to the person who is performing it.
That reduces the discrepancy, doesn't it?
Yeah, indeed.
Okay, all right. Thank you very much for those questions. And I'm just going to wrap it up now with a couple of summary slides. I suppose one of the things is that I've found it's creating a community a place where people can offer advice and help each other. And since we've been doing these webinars, I've got so many emails with questions and suggestions and ideas and things like that. One of them came from thank you very much, Dr. Jolien, for being with us again. That was really great. One of them, I encourage you to take a look at I Choose Health. Clinical nutritionist Megan has a special offer for people who want to look at a nutritional option. And there's you can go to her website there. And also, I really encourage you to take a look at the live laser and lymphedema course that Lymphoedema Education Solutions runs. And there's a registration. You can put your phone up to that and take a picture of it and register right now, or you can go to their website. But it's a comprehensive 3-part course online, and it's just a fantastic education about lymphedema and PBMT and laser. And for also, we work with the Australasian Lymphology Association and are happy to sponsor them and support them. And they're a great industry and professional association. Many of you belong to as well already. So I encourage you to become part of their association if you aren't already. And again, we'll be sending this out afterwards. But if you've got your camera there, your phone, you just scan this, and we've got a couple of special offers and some links to Jolien's research. And we'd love you to find out more from us if you're so interested. So Jolien, you're going to come back for one more goodbye for us. One more picture. There we go. Okay.
Of course.
Okay. Thank you so much again for being with us. And really, you've just been so generous with your time and your information. Thank you very much.
Thank you.
Okay, bye. See you next time.
Bye.
Okay.
Hope to see you soon.
Bye. Thanks very much,
Bye.
everyone. Good night.